Hello everyone, welcome to Physiology of the Male Reproductive System. Now, before you watch this, I highly encourage you to watch the anatomy section because remember, form follows function. So you must know anatomy before you go into this. It's going to be a little bit longer, but bear with me and let's jump right in, so buckle in. Okay, so it's beneficial to have an anatomy or model out here so that way you can kind of have this as a component. This is the physiology of the basic parts that are atypical that you don't normally see in a basic anatomy. So you have the seminal vesicles. They contribute 70% of the final seminal fluid. This fluid is relatively alkaline, which is important for counteracting the acidic environment of the vagina and also the urethra because urine is acidic. Now, sperm thrive in an alkaline environment, so if it's acidic, then you'll have denaturation of the enzymes and proteins that keep them alive. Now, the fluid contains fructose and seminal ghrelin, as well as proteins, enzymes, vitamins, zinc, and prostaglandins. We'll talk about zinc and seminal ghrelin later. Prostate gland is located inferiorly to this, and the basic purpose is mainly just to produce alkaline fluid to counteract vaginal acidity and urethral acidity, and also includes something very important called prostate-specific antigen. Lastly, we have the bulbourethral gland that produces more of the final seminal product and also lubricates the urethra, and we call that precum yeah. Now, erectile tissue, I remember the corpora cavernosa and the corpus spongiosum here. Those are the two erectile tissues. And a hormone that we need to remember is nitric oxide that promotes vasodilation of the erectile tissue. So you can infer that the cells within these erectile tissues secrete lots of nitrous oxide, or at least they have a lot of them ready for secretion to cause the vasodilation of the endothelium. So the engorging of blood vessels is also often called vasocongestion, and we have the nitric oxide molecule here. Alright, now circumcision is a huge and very important topic to cover in male physiology. It's a common alteration of the prepuce that can be performed on neonates after birth or during adulthood. This entails removing the prepuce or the foreskin surrounding the gland's penis. It's less common in developing countries such as Africa because of cost or access. It can also be less common for religious purposes, but the procedure is exceedingly common worldwide for its scientifically proven benefits and its haste. It reduces rates of UTIs and reduces cleaning hassle and eliminates potential penile problems such as phimosis and paraphimosis, which only occur in uncircumcised individuals. You have a lower risk of penile cancer. And then prepex device here, increases access to circumcision in developing countries. Basically cuts off the circulation of the foreskin covering the glands, so that way it can be a painless removal with scissors or a scalpel, whatever they have on hand. You can remove the foreskin without any pain. Let's get into the conditions, and there's a lot of them. So first is balanitis. We have basically inflammation of the gland's penis, and you can get discharge and blotchy rash, redness, swelling. So next we have phimosis. This is the inability to retract foreskin. This is more common, I remember, only on uncircumcised individuals, and it's where the foreskin kind of extends beyond what it normally does, and it's kind of hard to retract it. Now, paraphimosis is much more serious, and it's where you can't have the foreskin fold over the glands of the penis. This is a urologic emergency because it can constrict on the head of the penis and kind of cut off circulation. You can get necrosis of the gland's penis. Now, Peyronie's disease is very common, caused by the scarring of the corpora cavernosa. It can happen in both circumcised and uncircumcised individuals. And it's caused by fibrous plaque or collagen. Remember, in scarring, you have collagen that replaces the affected tissue. And you can infer that, well, if scar tissue replaces the corpora cavernosa, well, there's no sinusoids that can be filled with blood. So if this is not filled with blood, then it can't kind of counteract the effects of this corpus cavernosum. So it's going to fold upwards because this has more of a strength or a vector, so to speak, a force pushing upwards. Well, this one doesn't. So it's uneven, and this can be side to side, it can be up, down, any direction the penis kind of bends. Alright. and that's common in sexually active individuals, or damage of the penis. So, all right, next, penile cancer is a malignancy of the penis, penile tissue, erectile tissue, whatever. And then right here, this is very serious. You can tell it's cancer or a carcinoma because it's broken through the basal membrane and metastasized all over the penis. It's very, very rare. It's fewer than 20,000 annual cases, but the survivability rate is quite high. And unfortunately, penis is commonly resected as a treatment, so you gotta remove it. Benign prostatic hyperplasia is a condition affecting the prostate. This is an enlargement of the prostate. It's benign, which means there's no malignancy, but it can still be serious. Why? Why do you might have to take a quick guess. Well, the prostatic urethra is going to be compressed, and if that closes up, then you can't pee, and that's a urologic emergency. It can cause renal failure if it gets backed up. It's very common actually, and the risk increases with age, and it can obstruct prostatic urethra. It's obviously very serious. It can also cause difficulties peeing in the early stages. So orchitis is pretty simple. It's the inflammation of the testes due to infection, very commonly due to infection. And then epididymitis, which is also here, is just the inflammation of the epididymis. So we got swelling right here, posteriorly from the testis. Now testicular torsion is another urologic emergency, very serious. You can cut off circulation to the testicle and cause necrosis, and you're going to have to remove it. That's nothing to scoff at. It's pretty serious. This basically happens when the spermatocord rotates along its axis of the testicle. It can occlude testicular circulation, leading to necrosis of the tissue because there's no oxygen flowing here. And the treatment usually entails surgery, but sometimes doctors can go in and untwist it. Now varicocele is similar, but not as serious. Basically varicose veins within the testicular veins, and then I imagine you could probably see the swelling of the superior scrotum near the head of the epididymis, because the head of this right here. Now hydrocele is similar, but it's more inferiorly, and it's basically when a sac of fluid around the testicle forms, and that's when peritoneal fluid leaks through the membranes of the testicle and kind of forms this sac of fluid, this peritoneal cavity. And that's because the membranes are not really properly formed or weakened, and that can cause enlargement of the testicles. Alright, now let's talk about seminal emission. This occurs when seminal contents prepare for ejaculation in the posterior urethra. So basically the vas deferentia, or the vasa deferentia, the seminal vesicle, and the prostate gland all kind of contract to load the contents into the duct to prepare for the ejaculation. And then when it does ejaculate, the pelvic floor muscles and the urethra all contract to push the semen out. Now, this is going to be more of a hormonal thing, but this is also very important to remember for physiology of the male reproductive system. This is the HPG axis of the male reproductive system. This is hypothalamus, the pituitary, and the gonadal axis. And we're going to talk about the different hormones. Alright, so in the hypothalamus, GnRH is produced, and it goes and stimulates the release of the tropic hormones in the anterior pituitary gland, which is follicle stimulating hormone, luteinizing hormone. Luteinizing hormone kind of excites the Leydig cells, which produce the androgen testosterone, and then follicle stimulating hormone stimulates the Sertoli cells here, and the Sertoli cells secrete inhibin, which goes is antagonistic to GnRH, gonadotropin releasing hormone. So if it's antagonistic to GnRH, it will also be antagonistic to FSH and LH. And now testosterone, the androgen produced by Leydig cells, is also inhibitory to FSH and LH. And why? Because, well, if you didn't have anything to control it, then you would produce testosterone over and over, and too much testosterone. So we have testosterone go and say, hey, I'm already produced, I don't need you anymore. So why don't we go ahead and inhibit that until we need more testosterone? And testosterone goes and does the testosterone effects, and when testosterone is depleted, then the hypothalamus realizes that, and then GnRH starts to be produced, and then obviously more testosterone is produced. Alright. And that's why testosterone supplementation in male athletes or a lot of other athletes can not only cause aggression, but it can reduce the endogenous production of testosterone, which goes against the grain of what they're trying to achieve. So do not supplement on testosterone. It can be very dangerous if you're not prescribed it. Alright, and lastly I want to talk about the sperm coagulum here, and then the coagulum is just basically this kind of gel matrix that's formed after ejaculation. Now, remember we talked about the seminal vesicles producing seminal ghrelin, which forms a gel matrix. And seminal ghrelin is further enforced by zinc, so it triggers the formation of that gel matrix. And that holds the sperm in place when it's in the vagina. And why is that important? Well, because while it's traveling through the vaginal cavity in the uterus, it's going to be very acidic, and the sperm don't like that. So if they're protected by the gel, they won't be prematurely killed by the acidic environment. So it can have more survival rate of the sperm here, which is important. Now, prostate-specific antigen, which we talked about, is produced by the prostate gland, will come in and hydrolyze the sperm coagulum and capacitate the sperm. And this will happen at the right time, and then the sperm will go and try to fertilize the egg. So very important to have prostate-specific antigen, because if you don't, well, then you're going to be infertile. Very low chance of impregnating someone. Alright, well that was pretty much it for physiology of the male reproductive system, and I hope you guys took a few things from this kind of mini lecture here. I hope you guys do well in your courses. Alright, see ya.